Hi, Denise. Yes, I'm here.
Hi,
Thank you.
great. Hi, Dr. Cohen.
Hi.
All right. So good afternoon, everyone. And thank you for joining this live presentation in celebration of World Alzheimer's Day. My name is Denise Newton, and I'm the CEO at the Alzheimer's Society of Durham Region. Even though the COVID pandemic has restricted us from being together, we are most fortunate today to welcome our guest speaker, Dr. Sharon Cohen, who is joining us virtually to bring you current information on the latest advances in diagnosis and treatment and what the hopes, expectations, and challenges are for the coming years with respect to defeating Alzheimer's disease. As well, there will be ample time at the end to ask your questions of Dr. Cohen. So if you have questions, please enter them in the Q&A section found at the bottom of your screen. So it's my pleasure this afternoon to introduce Dr. Sharon Cohen. Dr. Cohen is a behavioral neurologist known for her excellence in patient care, teaching, and clinical research. She completed her neurology residency and behavioral neurology fellowship at the University of Toronto. She's the medical director and site principal investigator of the Toronto Memory Program, a community-based medical facility which she established in 1996 for the purposes of enhancing diagnosis, medical care, and therapeutic options for individuals with or at risk for Alzheimer's disease and related disorders. Her memory clinic and research site are among the most active in Canada. Dr. Cohen has over 28 years of experience in clinical research and has been a site principal investigator for over 100 pharmacological trials. In addition to her focus on Alzheimer's disease, she's also participated in pharmacological trials for acute stroke, frontal temporal dementia, Parkinson's disease dementia, Lewy body disease, Huntington's disease, and vascular dementia. Her research site has been credited as a go-to center for Alzheimer's trials and has been awarded for superior performance and quality in clinical research. Dr. Cohen represents Canada on international advisory boards and steering committees and is a consultant to a wide range of stakeholders in dementia, including government organizations and patient advocacy groups. She's a frequent lecturer and contributes to media events, including those on medical ethics. Dr. Cohen is known for her advocacy of individuals with neurodegenerative diseases. Despite holding academic and hospital appointments, Dr. Cohen chooses to practice in the community, in keeping with her belief that dementia care and clinical research are best offered in a real-world setting. Dr. Cohen, we welcome you today to help us celebrate World Alzheimer's Day and look forward to your presentation. Over to you.
Thank you so much, Denise. It's really a pleasure being with you. I do appreciate the invitation and the opportunity to speak with you and your group and your team, and I thank you for all of the work you're doing. I am going to share my slides now so we can get started. Let me just make sure I can find them. Okay, sorry about that. Can you see my slides?
Yes, we can.
Okay, excellent. Thank you. All right, so I do want to share with you hopeful news about what's happening in diagnosis and treatment for this very, very challenging disease that we call Alzheimer's disease. And so for the next 45 minutes, I will tell you what has been happening, and then I look forward to answering any questions that you have. So let's begin. My objectives are really to provide an update on recent research related to Alzheimer's disease, and that's research, as I said, to do with diagnosis and to do with treatment, because you can't hope to improve treatments if you can't properly diagnose a medical condition. Then I'd like to discuss what the impact of expected new treatments would have on our healthcare system. And we know from the COVID experience, it's not enough to have a breakthrough vaccine. You need a healthcare system in place that allows people who are eligible to get that vaccine. You need the cost covered. You need a system that's organized to deliver and keep track of who's vaccinated. And we'll see some similar parallels or challenges with Alzheimer's disease breakthrough treatments that we expect. I'd also finally like to provide a call to action for those interested. We often feel that there's not enough we can do, and yet in reality, we all have a role to play, and there are many things that one can do. So we'll return to that. So if we start with diagnosis, I want to explain to you how the diagnosis used to play out so that you see what's changing. So in 1906, Dr. Alois Alzheimer, a German neurologist and psychiatrist, reported on what was considered a rare disease. And he had studied a woman, a middle-aged woman who began to be forgetful in her 40s. He started following her at the age of 51. Her name was Auguste Dieter. She was a housewife in Germany. And by the age of 55, she died of her disease. He looked at her brain under the microscope and he saw plaques and tangles. He described these in a brief neurology journal paper, and this was the characteristic brain change of Alzheimer's disease, and that continues to be the case. If we fast forward to the current time, 2021, we know this is anything but a rare disease. It affects 50 million people, and the number is continuing to rise, so that by 2050, there'll be about 150 million people if we don't do something to stop this disease. And here you see faces of some of the famous politicians or actors, celebrities who have been affected by the disease, mainly later in life, age 65 years and older. However, we know that Alzheimer's disease can start at a young age, and about 8%, so not the majority, but 8% of individuals with Alzheimer's disease start their symptoms as young as in their 40s or 50s. And you see here on the left, a musician, a Canadian musician, John Mann, who died of Alzheimer's disease a couple of years ago at the age of 57. And on the right, you see the actress Julianne Moore, who played Alice in the movie Still Alice, and she was diagnosed with Alzheimer's disease at age 50. So the World Health Organization in 2012 already considered Alzheimer's disease to be an urgent healthcare priority because the numbers were rising and so high, and the disease is incredibly serious. It takes a very great financial toll as well on the healthcare system and also on the individual and their finances, the family finances. And despite the disease being common, diagnosis is fraught with underdiagnosis, misdiagnosis, and late diagnosis, with only about 50% of patients ever getting a proper diagnosis, and often after several years for those who do end up with a diagnosis. So why is this so challenging? Well, we might not think it's so difficult when somebody is very impaired, doesn't know who they are, where they live. Even then, there could be causes other than Alzheimer's disease. But many patients, especially at the beginning of the disease, don't recognize that something's going wrong with their memory. In effect, they don't remember what they don't remember, and therefore may not come forward and report symptoms. For those who do recognize there's a change, and many people who are developing Alzheimer's disease actually are insightful that something's going on, they may not come forward because of fear of stigma or fear of losing their driver's license, fear of being a burden. So many reasons why people may not report their symptoms. Physicians often lack skill and sometimes lack interest in diagnosing Alzheimer's disease because they have a sense that they don't have much to offer. And so I'm sure many of you have been in the situation or heard of the situation where a patient or family are concerned and do seek the advice of their family doctor and are rather discouraged that the family doctor may not show much interest or may be falsely reassuring that not too much is wrong. And the symptoms are often confused, especially at the early stage, with just normal aging, or put down to normal aging, shall I say. What do you expect for being 70 or 80? You're going to be a bit forgetful. That's absolutely not the right way to approach this. What if we did that with cancer and said, oh, well, it's just a tiny lump, it's not too significant. I mean, if that's the opportunity to detect a serious cancer, then we better jump at the tiny lump. And same should apply to early memory symptoms. And then even for the patient who comes forward and for the physician who is conscientious and does some cognitive testing, those tests may not be sensitive for early changes in memory. And so we may be falsely reassured that nothing's wrong because a test score is normal. What we understand, however, is that Alzheimer's disease is a very long, slowly progressive disease, and it lasts about 30 years. So although people often develop symptoms over the age of 65 in their senior years, the disease is beginning in the brain in midlife. And changes in the brain start accumulating for about 15 to 20 years before enough brain cells are injured that we get to the mild cognitive impairment stage. So this silent stage where there may be no symptoms or only very subtle memory symptoms is called the preclinical stage of Alzheimer's disease. And seamlessly it merges into or progresses into the mild cognitive impairment or MCI stage. And at that stage, for about 5 years, individuals are functioning independently, and yet their memory is not normal. They have symptoms. If we do cognitive testing, we can see there's an impairment in memory, and yet the individual is able to compensate and still bank, shop, drive, do whatever is usual for them. Gradually, the mild cognitive impairment stage of Alzheimer's disease will give way to the dementia stage, which is usually broken down into mild, moderate, and severe dementia and lasts overall about 10 years. And during the dementia stage, one loses the ability to perform tasks independently. Initially, this might be banking, but in later stages, it might be dressing oneself, toileting, feeding oneself. So there's a progressive loss, a slow but progressive loss of independence in day-to-day activities. Throughout this entire process, right from the beginning, two bad actors called amyloid and tau are building up in the brain. And these are the plaque and the tangle that Dr. Alwa Alzheimer saw under his light microscope. He didn't know what these proteins were made of. He didn't have the names amyloid and tau. That came more recently. And he didn't know how they got there or how they could perhaps be removed. And yet this was the hallmark still of Alzheimer's. Excuse me. Excuse me. When this disease progresses, what you see is the whole brain shrinks. And that is because brain cells are dying and dropping out. This doesn't happen overnight. This happens gradually over many years. And so you see a shrunken brain. And if you look under the microscope, you see the plaques and tangles or the amyloid and tau. But that's not helpful if we make the diagnosis at autopsy. It's certainly not helpful to the person who has now passed on. So the big question is, can we make the diagnosis while people are still alive? Can we be accurate with it? And can we make it early in the disease, not just once the disease has taken substantial hold, but even earlier, perhaps in the stage where there are no symptoms? And the answer is unequivocally yes. We now have the tools to make accurate diagnoses in life and early on. And these tools are a PET scan using an amyloid tracer. And we have these in Canada. They've been approved in the US, the amyloid tracers, for some time now. We have one amyloid tracer approved in Canada. We also can do spinal taps and examine spinal fluid, and this gives us good information about the amyloid levels, not just in the spinal fluid, but in the brain, and also levels of tau. And this is very, very important because what this means is that Alzheimer's disease is no longer a disease that you diagnose at autopsy. And you might still hear people say that you can't be sure without an autopsy. That's not true anymore. And it's no longer a diagnosis of exclusion. And when a physician says a diagnosis of exclusion, what they mean is you rule out a head injury, you rule out depression, you rule out a stroke, And if you don't find any of these other things, then you say it's probably Alzheimer's disease. Well, that's what we were doing up until a few years ago, and now that's just not good enough because we owe people an accurate diagnosis, not just a diagnosis of what it isn't. So once we are able to clearly identify a disease, then we can test treatments, we can accelerate the progress of new therapies, just the way we couldn't make a vaccine to the coronavirus unless we could isolate that virus. So it's exactly the same principle. And once you diagnose something early, whether it's in dementia or in oncology, cancer medicine, or anything else, infectious disease, the earlier you diagnose, usually the better the outcomes because less of the brain in this case is damaged. So here's a picture of someone having a PET scan. It looks like a CAT scan type of machine. A tracer, an amyloid tracer is injected. And on the right, you see an image, a PET scan image of the brain, and all of the red is amyloid. So this person has a brain that is actually full of amyloid. That doesn't mean that they are advanced in the dementia stage. It just means they have the Alzheimer's changes in the brain. They might not even have any symptoms. So that's how powerful this technology is. Spinal taps, we do very frequently in our office. We do it as an outpatient procedure. It's very well tolerated. And we send the fluid, you might be surprised to hear it, to a lab in Amsterdam. And within 10 days, we get the results. And the results are as accurate as the PET scan. So why aren't all the memory doctors and memory clinics doing this? And why don't family doctors know about these diagnostic tests? Well, PET scans are expensive and they're not yet covered by OHIP. We believe that will change, and it's going to take a lot of advocacy and some breakthrough therapies to make that happen. The PET tracers are not produced in enough supply, and we don't have enough PET scanners in the country, let alone in the Greater Toronto area. As far as spinal fluid analysis, this does require a spinal tap, and although this is a fairly easy outpatient procedure, some people are averse to it. Some people won't be able to have it because of previous spinal surgery or being on blood thinners. And it also requires, at the moment, shipping of spinal fluid to an out-of-country lab. So the holy grail for diagnosing Alzheimer's disease has been a blood test, and blood tests are coming. And in the United States, last fall, the first blood test to give a readout on an estimate of brain amyloid was a blood test called Precivityy. This is available throughout the United States, not yet in Canada, and it measures the amyloid level in the blood to predict the brain blood level. And we expect in the next 1 to 2 years that blood tests will be much more widespread. There will be other amyloid blood tests, there will be some tau blood tests, and there will be blood tests that are markers of how far along the disease has progressed, not just whether the disease is there, but is it at the mild or moderate stage, is it at the mild cognitive impairment stage, and that will help with what the appropriate treatments might be and the prognosis. Where is somebody in their disease? Another technology that's moving forward is a retinal scan, and this is a picture of the back of the eye. The back of the eye, the optic nerve, is actually the front of the brain, and we can see the signature of amyloid in the retina. And just the way ophthalmologists and optometrists take pictures of the eye to look for various other eye conditions like macular degeneration, so too with this special camera, a hyperspectral camera, are we able to see the signature of amyloid accumulation in the back of the eye, reflecting accumulation in the brain. So at Toronto Memory Program, one of the studies we're involved in is validating the retinal scan to see if it is as accurate as the spinal fluid or PET scan for detecting Alzheimer's disease. And then there are genetic tests. Some people have their Alzheimer's disease on the basis of a gene mutation. Now, these gene mutations are rare, but we can test for them. And in a scenario where one has several family members who've had Alzheimer's disease, or individuals in the family who have had a young age of onset of symptoms of Alzheimer's disease, it would be appropriate to check for a gene mutation. Fortunately, the cost of this genetic test is covered in Ontario, and we perform these blood tests on people who want to know, and those who have genes that cause Alzheimer's disease have options for prevention and treatment studies. Now, it's said that the gene mutations that cause Alzheimer's disease are rare. That is true. For the majority of us, the genetic component of Alzheimer's disease comes from risk genes and a balance of risk and preventative genes. And this is true for all diseases. For Alzheimer's disease, the ApoE gene, some of you might have heard of this gene, is the gene that confers the most important risk for Alzheimer's disease, and specifically it's the ApoE4 type of ApoE that causes increased risk. We can check for this with a blood test or a cheek swab, and again, the cost is covered. And people who want to know about their risk for Alzheimer's disease, they're curious, they may have a family member with the disease, they may have mild memory symptoms. For whatever reason, we can organize this. We do this regularly. And here you see a picture of Kathy Barrick, who's the CEO of the Alzheimer's Society of Ontario, who came to us saying she wanted to have a cheek swab. She wanted to help with research, and she wanted to let people know that this is not so scary. So she led by example, came to our clinic, had a cheek swab. And you see on the right a picture of the Spartan Cube, which is the smallest DNA analyzer in the world. It's a 4 by 4 inch technology in the shape of a cube. And we put the cheek swab specimen in and run it for just an hour and get a result. And the kind of result we can get is whether one has any copies of ApoE4. If you have one copy, you have a 3-fold greater risk of Alzheimer's disease. If you have 2 copies of ApoE4, a 10-fold greater risk. And then there are, again, clinical trial treatment options for people who may be in the higher risk category. So let's talk about treatment now. We spent some time talking about what's new in diagnosis, but the treatment pipeline is moving along, and that's very exciting. And it's been quite dependent on us being able to properly identify people with Alzheimer's disease. The existing medicines, some of you will be aware of. These have been around since around 1997, 2000. There are 2 classes of approved medicines. One boosts a chemical in the brain called acetylcholine. The other boosts a chemical called glutamate. They all work downstream on boosting chemicals in the brain. They don't get at the underlying amyloid or tau. They treat symptoms with modest effect, so they're worth trying, but they're not powerful enough to arrest the disease or to give a complete reversal of symptoms. And of note, none of them are approved for the mild cognitive impairment stage of Alzheimer's disease, only for the later dementia stage. So after many failures in Alzheimer's research, we are absolutely due for a breakthrough, and there is new hope emerging on the treatment side. The drugs being tested and the clinical trial designs are much more sophisticated than they were before. Not too long ago, we didn't even know if the people we were studying actually had Alzheimer's disease because we didn't have PET scans or spinal fluid to determine who was in the cohort. So it really, really didn't help with drug development. Now we are much more precise. Also, the financial investment in Alzheimer's research has increased. It's always lagged behind cancer medicine and other therapeutic areas, but it has increased in recent years. And very hopeful, a first disease-modifying or disease-slowing drug has just been approved by the FDA, and we'll talk more about that. That's a drug called aducanumab, or Aduhelm is the brand name, and it was just approved in June of this year. Before we talk about that new drug, I want you to see what the current Alzheimer's drug development pipeline is. And this is a very overwhelming slide, so don't let it scare you. You've got 3 circles here and a whole bunch of little shapes. So each little square or circle or diamond or triangle represents a unique drug that's being tested, not yet approved, but being tested for treatment of Alzheimer's disease. And the outer circle includes drugs that are at phase 1 of development, so early in their development. Then the the middle circle is the drugs in phase 2 of development, while the inner circle represents drugs that are in phase 3, and that is the last stage of drug development. If a drug is successful in its phase 3 program, then the developer of the drug can take that dossier to the regulators, the FDA, Health Canada, the European Medicines Agency, whichever regulator, or all of them, to ask for a license to market the drug. So we have, as you see, drugs at all stages of development, phase 1, phase 2, phase 3. That's good because drugs are going to drop out as they progress from phase 1 to phase 2. Maybe they're not safe enough, maybe they don't do what we need them to do. And as you study in higher phases, larger numbers of people, you will get clearer and clearer answers about how good your drug is. What you see with the colors of the shapes is that all of the red compounds are compounds that tackle amyloid. And amyloid is a sticky protein that is the first change we see in the brain developing Alzheimer's disease. So many different compounds that in different ways tackle amyloid. In blue, in dark blue, you see compounds that tackle tau. So another toxic protein, as I've mentioned, has some therapies directed specifically at tau. And the yellow compounds are compounds that deal with inflammation in the brain. Alzheimer's disease is a very complicated disease. It's not just the accumulation of amyloid or the accumulation of tau, but there's also an inflammatory response. There's a lot of inflammation going on in the brain. And there are other things going on in the Alzheimer's brain as well. So you see other colored shapes that are tackling different aspects of the disease. So this is very hopeful. We're not putting all our eggs in one basket. We have many different compounds with different mechanisms of dealing with the disease. And finally, also hopeful, is the fact that we are not just involving people at the dementia stage or the mild cognitive impairment stage with clinical trial enrollment. We are spreading our trials across the full spectrum. So individuals who are at the preclinical or pre-symptomatic stage have a shot at prevention. Individuals in the mild cognitive impairment stage have a host of trials that are appropriate for their early symptomatic stage. And then people with the dementia stage of Alzheimer's disease also have opportunities for trials. So this is quite different than just a few years ago where all of the treatments were at the dementia stage and usually at the moderate to severe stage, because we didn't have a way of knowing earlier in the disease that we were really dealing with Alzheimer's disease. So now I'm going to revert back to aducanumab, this first drug that was approved in the US in June. In 2016, this picture appeared on the cover of Nature magazine. And this is a before and after shot with the before PET scan on your left and the after on your right, the same patient with Alzheimer's disease who had a head full of this red amyloid on the PET scan. And after 10 treatments, intravenous treatments of this antibody, aducanumab, had no amyloid. It was all removed. And this was the result of a phase 1 study in 2016. And that led to further study, and the phase 3 program read out. And that phase 3 program led to the approval of aducanumab, June 7, 2021, by the FDA for treatment of Alzheimer's disease. And we'll talk more about that in a moment. This is not yet approved in Canada. It is under review by Health Canada. It is also, aducanumab is also under review by several other regulators around the world. So we expect it to be approved in other jurisdictions, but we won't know, until the regulators give their answer. So why does it matter? Well, it does matter because if this is going to be approved in Canada, we need to get ready for it. We need to understand it, and we need to adjust our healthcare system as they are trying to do in the US where it is approved. So this is an antibody that clears amyloid from the brain. And in one of its phase 3 studies that was conducted in people with mild cognitive impairment and mild Alzheimer's disease dementia, there was less decline over 18 months in cognition. There was slowing of decline in activities of daily living. So day-to-day function was also preserved. There was less emergence of psychiatric symptoms, so less agitation, less anxiety, less irritability, various symptoms that can accompany even the mild stages of Alzheimer's disease. There was a dramatic clearance of amyloid from the brain, and there was also an impact on tau and brain cell loss. So even though the antibody only clears amyloid, it had an effect on downstream brain changes that suggest that removing amyloid will also protect the brain from other types of injury. So it's the first drug approved in 18 years in the US. Will be the same in Canada. The last drug we had approved for Alzheimer's disease was memantine in 2003. Aducanumab is the first drug approved in the US to clear amyloid from the brain, and the first drug for MCI, not just the dementia stage. And it's the first drug for Alzheimer's disease to be given by intravenous infusion rather than a pill. And it is the first drug that requires an amyloid test to confirm the diagnosis. And this is the finding of the appropriate use criteria, consensus criteria, not so much the FDA, that in order for a physician in the US to prescribe aducanumab, the patient must have an amyloid test. And hence Medicare and Medicaid in the US are looking into whether they will fund the testing, the amyloid test, which is needed. The drug use also requires some monitoring by MRI scan to make sure that one is not getting into side effects of temporary brain swelling. So MRI scans are part of the regimen for this treatment. Now, when you have a new drug approved, that is the first in its class in any therapeutic area, whether it's in cancer medicine or multiple sclerosis or rheumatology, that generally leads to an acceleration of the treatment pipeline. It leads to greater innovation, and it leads to system change. And within just 2 weeks of the FDA granting approval to aducanumab, we saw the FDA grant breakthrough therapy designation to 2 additional anti-amyloid drugs, so separate compounds, separate companies. One, lecanemab, which is being developed by Eisai, another called donanemab. They all have funny names. This one's being developed by Eli Lilly. And so what breakthrough therapy designation means when granted by the FDA is that the FDA feels that these programs hold a great deal of promise. These drugs hold a great deal of promise, and the FDA wants to interact more closely with the developers to give more input and guidance on the drug development process in the hope of speeding it up and optimizing the chance of success. So importantly, lecanemab, an anti-amyloid drug, is already in phase 3 for early Alzheimer's disease. That program is fully enrolled, and we expect a readout in about 18 months. But it is also in a prevention trial, which will begin at Toronto Memory Program in November of this year. So for people who may feel they're at risk for Alzheimer's disease, but are still cognitively normal. So that prevention trial is of high interest for many people, and that will be available to anyone in Ontario who's interested. As far as donanemab, it is also in phase 3 study for people with mild cognitive impairment and dementia, mild dementia. and it is still enrolling. And actually, there's a rare opportunity for an open label participation, meaning no chance of placebo. So that's exciting, but only probably for the next month or so. And Eli Lilly, the developer of donanemab, plans to file for FDA approval this year for treatment of Alzheimer's disease. And they are planning a phase 3 prevention study as well. So a lot is happening. And it's not just aducanumab. We have aducanumab plus 2 other drugs that might come fairly soon to treatment for patients, to the commercialization stage. And that's after 18 years of no new treatments. And then, as you saw from my complicated diagram with the 3 circles, there are many other disease modifying or disease slowing treatments, including the anti-tau treatments and treatments to tackle the immune system. And they're all very different. So for the immune system, there are drugs that reduce inflammation in the brain. There are drugs that activate immune cells to help clear amyloid and other toxins. And there are drugs that are geared to boosting the protective function of support cells in the brain. So many different approaches, and it's quite possible that using these approaches in combination will be a path forward as well. Just the way we have with treating diabetes or even hypertension, it often takes a couple of drugs or a combination of 2 or 3 drugs to get the best control of the disease. And slowing down the disease is very important, especially if you can catch it at the mild stages where people are doing well and keep them functioning and living at home and in the community. But treating symptoms is also important. And there is a drug called GV971. It was approved in China in 2019 for the treatment of symptoms in Alzheimer's disease. And it is an extract of seaweed, of brown algae. It's a very, very well tolerated plant extract. And what it does is it works actually on the immune system by altering the microbacteria composition of the gut, of the gastrointestinal tract, which in turn renders the brain less inflammatory. So what was seen in the Chinese phase 3 study was that for this symptom approach, there was a much more rapid and much greater magnitude of symptom benefit than what we see with our traditional symptom treatments, the Aricept, donepezil kind of drugs, and that the symptom benefit lasted for a longer time than what we're used to. So now there's a global phase 3 study. Again, this is going on at Toronto Memory Program. I don't think I mentioned most of these studies are going on at Toronto Memory Program, and we are always interested in volunteers and participants from all over Ontario. And so this particular medicine, GV971, works best when people are not on the background standard therapies, the Aricept types of drugs, because those drugs don't allow GV971 to change the microbiome or the microbacterial composition of the gut. So for people who haven't been able to tolerate the standard medicines or who haven't started a standard medicine, this might be something of interest. So now in the last part, I just wanted to speak briefly with you about how are we going to do this? I am quite sure we're going to have new therapies in Canada, whether it's aducanumab or lecanemab, donanemab, or an anti-tau, or whatever it is, we're going to have more than one in the next years. So we need the public to know that it's worth stepping forward and saying, I'm worried about my memory. Is there anything I should be doing? We want to improve awareness and knowledge at the family practitioner and specialist level as well, that it is worth making a diagnosis. It's important so that you can then guide people to treatments that are coming or may be already available. We need to improve access of Canadians to the technology, to the amyloid test. We need to make it accessible and we need to make it affordable. And we need memory clinics to be better resourced So their wait lists are not 6 months to a year, and that's particularly difficult when somebody's sitting on a wait list for a long time and perhaps gradually getting worse while they're waiting to see a specialist. We need infusion centers if these new therapies are going to be delivered by intravenous treatment. So that's more complicated than just getting a bottle of pills and taking them at home. One would need to either go to an infusion center, hopefully not in a hospital, we would prefer not, but maybe a standalone infusion center, or get the treatment in the doctor's office, or perhaps through home infusions. That would be another option. We need to make sure that there's improved access to MRI scans. And for the most part, we can get MRI scans fairly readily now, but with a large number of individuals who will come forward and be eligible for new treatments, that will place a significant burden on the MRI wait time. So that also has to be scaled up. And we need sustainable funding for Alzheimer's disease, for treatment and for care, because as more people come forward and are identified, we will need more programs, we will need care navigators. It's not all about the drugs. The medications are very important, but lifestyle factors and keeping people safe and supported in the community, these are very important as well. So education, that's what we're doing together today, establishing regional diagnosis and treatment centers of excellence. That may be one way that we can coordinate better care at the medical level, creating new roles like the AD care navigators, creating a lab in Canada for analysis of spinal fluid and blood test results. That would be great, so we're not shipping biological specimens to out-of-country labs, and then the cost will come down as well. And we need to change the funding model in Alzheimer's disease so costs are covered. So don't doubt progress, help accelerate it. People who know this disease, as you and I do, want to be involved, and we need to let politicians know that Alzheimer's is important. We had very little opportunity in this election that's just run its course to really make some noise about what's happened with seniors in long-term care during the pandemic and in general. And so many of those seniors were people with Alzheimer's disease. So we need this to be an ongoing effort to advocate on the political scene. Have a baseline memory test. We offer free memory testing, and I will give you the name of our contact individual. Lindsay Snow is actually on the meeting with us today, but we can arrange this for you easily. You can join a prevention or treatment registry. We have a large registry. Lots of people are interested in particular trials or whether there's a good fit. We'll keep you apprised of that. You can find out if a clinical trial is right for you, whether it's a prevention trial or treatment trial or mild cognitive impairment trial. We have quite a broad menu of international studies. And cheek swab, you could undergo a cheek swab and look for whether you have a risk gene for Alzheimer's disease. So lots to be done, and we all have a role to play. So we want to look after ourselves, the people we love, and protect next generations, because our kids and our grandchildren will have enough to worry about in this world without also having to worry about Alzheimer's disease. Here are two wonderful people I work with. And as I mentioned, Lindsay Snow is in the meeting with us. You can connect with either Lindsay or Justine through our phone line. You don't have to be referred. You can just call us at this phone number or email us, research@memorydisorders.ca, to have whatever questions answered. Don't be shy. We're here to help. And we are not a boutique medical clinic. We're an OHIP covered medical clinic. There's no cost to you, and anybody who engages in the research program, all of that's covered by research grants. So I don't want anybody to worry about that. We don't have a catchment area. We are open and available to whoever needs our help. So with that, I will stop sharing my screen, and maybe we can engage in questions and answers, and I'd be delighted to hear your thoughts.
Thanks, Dr. Cohen. It's always great to hear the latest research and news, and we certainly, in celebration of World Alzheimer's Day, quite fitting that you're here sharing the latest news with us. So Now it's an opportunity for you to ask questions. On the bottom of your screen, you have a Q&A option that you can click on, and you can type your question in. As well, if you prefer to ask the question, if you raise your hand, my colleague Sarah and I will unmute you and you can ask your question live.
We have a very quiet audience today, Dawn.
We do. The first one to go is always the toughest one, but I see where people are asking, so.
All right, I have one question. This individual asks, is there any possible new medications to treat vascular dementia?
Yeah, thank you. That's a great question. And of course, it's not all Alzheimer's disease. Stroke-related or vascular dementia is an important entity. There isn't a new medicine to treat vascular dementia. The efforts to prevent stroke have resulted in a lower incidence of vascular dementia. I'm not saying it doesn't happen, people still have strokes, but the stroke rate is actually going down. And that is because of better control of vascular risk factors. So heart disease, better control of blood pressure, lower blood pressure targets than we previously had, smoking cessation, treating cholesterol. So the prevention side has really resulted in a lower incidence of vascular dementia, but no new treatments for those who have vascular dementia.
All right, thank you, Dr. Cohen. We have an individual, an attendee named Trish, who raised their hand. So Trish, I'm just going to give you the option, allow to talk. So you should be able to unmute yourself and ask your question.
Okay, thank you very much. Can you hear me?
Yes.
Yep.
Okay, my question is, well, it was such an excellent presentation and there's so much to digest that I think that's part of why I can't really formulate a question right now, because so many answers were given that were amazing. But I'm just curious, because of that, will we be sent a copy of the presentation in order to try to digest it a little bit further by chance, by email? Thank you.
Trish, I appreciate you asking. Unfortunately, I can't share my slides because of copyright issues. So I do appreciate there's a lot of information there. And I wish I had a different answer for you, but I cannot share my slides. I'm sorry.
Can I just interject the recording that we have made a recording, and Dawn, maybe you can help me with the recording will be up where for people to view again, if should they so wish.
So Dr. Cohen, as long as you're okay with us sharing the recorded content, we will have it available on a private YouTube channel. So you can email, and I'll just put our email in the chat. You can email education@alzheimerdurham.com, and we can send that out to you.
Perfect. Thank you so much. I appreciate that. That's great. I realize it is a lot of information to go on, and I'm glad the recording was made. Thank you.
All right, so thank you, Trish. And looks like we have another individual who has raised their hand. So Norma, I'm also going to give you the ability to now unmute yourself and chat.
Yes, thank you, Doctor. It was a wonderful presentation. So much information.
Thank you.
I'm wondering about these new medications. Can a person who has been on something like Aricept be switched to one of these new medications, or is it just for people who are newly diagnosed?
Yeah, that's a great question. So the answer is that these medicines can be used together. So if somebody was on Aricept or one of the other standard of care medicines, and they were benefiting from the medicine, or even if they weren't sure but wanted to stay on it, the new medicine, like aducanumab, can be added to it. There's no worrisome interaction. There's no diminution of the effect of the medicines when they're used in combination. So yes, they can be used together, and that is the way it's rolling out in the United States right now, where the new medicine is available. And that will be true for the other medicines coming. They are all being tested in clinical trials in combination with the existing medicine.
All right, thank you, Norma. So I'm just going to pop you off then. Oh, if you have another question, you're free to go ahead then.
I think I'm trying to lower my hand here.
You got it. All right, there we go. All right, and if anybody else has any other questions or just comments in general, as Dawn mentioned, feel free to put them down into the Q&A section or the chat as well. Or once again, if you're more comfortable asking your question directly to Dr. Cohen by speaking for yourself, then you're more than free to do so. Just make sure you just use the raise hand feature.
We are receiving some comments just back, Dr. Cohen. So thank you for sharing this. I was unaware of the progress being made, and fantastic to hear about the advancements in Alzheimer's disease research, especially preclinical diagnosis. Thank you for the information. So
you're so welcome. I really regret that people are not more aware, and how could you be? I mean, it's a complicated field, and it's not something your family doctor is going to easily know about. So I'm delighted to share with you that yes, although it seems like nothing's been going on in the last 18 years and we've had no new treatments for this really, really tough disease, actually there's been a lot of progress. It's been very stepwise, one thing building on another, and now we're poised to see the field accelerate and open up. So I'm so glad to share it with you. Thank you.
Great. We have another raised hand from Trish. So Trish, there you go.
Hi, thanks again. Sorry, I just thought of something. So I have been genetic tested through the program 23andMe that said I did have the gene for Alzheimer's. So say, for example, I came to your clinic as you advised us that we might be able to be cheek swabbed, and you confirmed that I do have the gene. Is there any way to know, like, either a threshold or no, because my 23andMe genetic testing was done a couple of years ago. Is it like just a gene is a gene, and if you have it, then you have it, or would there be follow-up potentially with the clinic that maybe something has progressed further at that point? I'm not making myself very clear, but hope you're such a good speaker, you'll figure it out.
You are very clear, Trish. Thank you for sharing. I appreciate that. I'm sure other people are interested in what you're saying. So 23andMe, that's a direct-to-consumer genetic test outfit. When they do genetic testing for Alzheimer's, it's the ApoE gene that they test. So they don't test for the gene mutations or other risk genes. So specifically ApoE. And I'm not sure, you said you have the gene, so I don't know if you have one copy of the ApoE4 gene or two copies, and you don't need to share that with us, but we would certainly take that into consideration in terms of that as a risk factor, the ApoE4 and one or two copies, and then look at, in conjunction with you, what other risk factors, genetic and non-genetic, you might have in terms of family history, any memory symptoms, any other things that might be risk factors. And then we'd have some options, but we do monitor people who have one or two copies of ApoE4 because we know there's an increased risk of Alzheimer's, but it's not a guarantee that you will develop Alzheimer's. So if there's good news from today and from your question, having that gene is a risk gene. But if you think about it, like, people who have fair skin are at higher risk for skin cancer than those with dark skin, very much higher risk, but not all of us fair-skinned folks develop skin cancer. So we're at risk, but it's not guaranteed. So that's the same with the ApoE gene. So there are therapies coming that may make it less likely for someone who has this ApoE4 risk gene to develop Alzheimer's, so to mitigate the risk. If there's a strong family history, we would do genetic testing beyond ApoE. We would look for the deterministic gene mutations that are actually causative of Alzheimer's, so that may or may not apply in your situation, but you can sort of get the feeling there's quite a bit more that could be done, both in terms of clarifying the risk and also potentially starting a prevention.
Okay, thank you very much.
You're so welcome, Trish.
All right, thank you, Trish. We do have another question down the chat. So this individual, they say, you know, they love the information, fantastic presentation. They are asking, in terms of our other dementias, such as we already talked about vascular dementia and frontotemporal, are there any kind of drugs to maybe help? Sorry, let me just double check the question, make sure I'm reading it properly. Dawn, if you might want to jump in just to make sure I got this. But are there any also drugs available for these other dementias, such as like Lewy bodies, for example?
Yes, so great question. And these other diseases don't get enough attention. They affect fewer people than Alzheimer's disease, but they are important and serious diseases, Lewy body disease, frontotemporal degeneration, and others. The part of the problem in the development of treatments, excuse me, for these diseases is the diagnosis problem. So let me explain. Lewy body disease is a disease of a protein called synuclein or alpha-synuclein. So just like it's amyloid and tau in Alzheimer's, it's alpha-synuclein in Lewy body disease. We cannot measure that with a PET scan or in the spinal fluid. We can see it at autopsy, we know it's there. And so it makes it harder to study this disease from a prevention standpoint. However, there is an antibody being tested that is designed to reduce alpha-synuclein in the brain. And actually, we're running that study at Toronto Memory Program. So if you know somebody with Lewy body disease or Parkinson's disease related dementia, we have that opportunity. So we are looking forward to these biologic therapies also applying to Parkinson's. So it's not amyloid or tau, but synuclein, the alpha-synuclein we need to remove in Lewy body disease and Parkinson's. For frontotemporal degeneration, and that's an umbrella term for a number of diseases, PSP and Pick's disease and others, tau is the offending agent, and it's possible that some of the anti-tau therapies that are being developed for Alzheimer's disease may pave the way to new treatments for frontotemporal dementia. But now we're really looking to accelerate what's going on in Alzheimer's disease to help not just that disease, but the other dementias. So I wish that the short answer was, yes, here's the new drug for this and this. We're not quite there yet. But there are trials definitely for Parkinson's and Lewy body disease dementia. Yes.
All right, thank you. We have two more questions. So our first one here, it says, where can a family doctor obtain information and to do testing for Alzheimer's disease or dementia if a patient is requesting it?
Yeah, great question. So the family doctor will not have these tools available to make a specific diagnosis. What we would hope is that the family doctor would listen, would take interest, might do a screening memory test, and then refer on and do some basic blood tests to rule out thyroid disease or B12 deficiency or some of these other things that can put people at risk for memory problems. But the family doctor at this point wouldn't have access to more specific tests to rule in Alzheimer's disease. They wouldn't be able to order the PET scans or orchestrate the spinal taps. So a specialized clinic like ours would be able to, and we'd be happy to serve whoever is asking the question.
All right, thank you. And we have our other question. This individual is saying they wonder if there is a direct connection between reducing the amyloid in the brain as taking aducanumab. I apologize if I mispronounce it. If there is a connection between taking that and cognitive decline or behavioral symptoms of Alzheimer's disease.
So what we believe is aducanumab, which is this new treatment, slows the progression of symptoms, slows the progression of the disease by removing amyloid from the brain. And in doing so, people are functioning better. They're staying at the milder stage of Alzheimer's disease longer and are therefore able to function in the community independently. So there seems to be a direct impact on the more amyloid that you remove from the brain, the better people do in day-to-day life.
Great, thank you. So Dawn, I still believe we do have some time left. If we have any other questions or comments, anything anybody would like to pop down in the chat or the Q&A, or they would like to be unmuted and again, use their voice.
Dr. Cohen, I don't see anything yet, but I did want to ask a question because it is World Alzheimer's Day. What do you suggest to anyone who maybe is on the call today that doesn't necessarily have someone in their life who's living with dementia, or maybe they do, and what can they do to help with awareness and to start the conversation around supporting people with dementia?
Yeah, thank you. That's a great question, Dawn. So, the disease is so common that many of us do know somebody with the disease or have somebody in our family. But not all of us, and thank goodness, not everybody has to have personal experience with the disease. But having an open attitude towards seniors, being more vigilant about seniors perhaps needing help, whether they're in the grocery store or in the pharmacy, being aware that cognitive problems are very common and that it may take repeating things or just a gentler approach with people and they'll do better. That is often helpful, even though we're not asking that we go into the community and make diagnoses here. But the disease is so prevalent that the older the individual you're dealing with, the more likely they have some degree of cognitive impairment. So I would say, speak plainly to people, don't speak down to people, but be willing to repeat oneself and to be supportive if somebody's not grasping the first time. I think it's also important to look after oneself and to know that this disease can strike any of us. And even if we live a healthy lifestyle, it's diseases aren't fair. So let's say we eat well and we exercise and we use our brains, and so we've built up some cognitive reserve. I think that that's a lifelong process. It's not that I used to be active or eat well. We should continue those practices now in the hope of keeping our risk as low as we can. And in the future, there will be other things we can do to stay active and healthy into later years.
All right, so it looks like we have a couple more questions. So we have one in the chat, and it says, where does aphasia fit under the umbrella of Alzheimer's disease or dementia?
Okay, that's a smart question. So aphasia describes a language disturbance. And so unlike, slurred speech or not being able to pronounce things, aphasia is a disorder or a group of disorders where one can't find the words or string the words together properly to make sense or can't understand what other people are saying. And that happens most commonly with stroke. If there's a stroke in the language area of the brain, one can suddenly be very unable to communicate. But it also happens very commonly as part of Alzheimer's disease. So Alzheimer's disease is more than a disease of memory. It affects the language part of the brain. It affects other cognitive parts of the brain as well. The difference in the aphasia in Alzheimer's disease is that it's very subtle in the beginning. It starts with word finding difficulties, tip of the tongue, I know that person's name, I can't think of it. We all have that, and we can all be very sympathetic to somebody who can't come up with the word. But over time, that becomes more and more frequent for that individual's baseline. And we're all different. Some of us are very fluent and grab words easily, and others always struggle for words. But what is normal for any one individual starts changing, and more word finding problems, more name finding problems. And that is the beginning of the aphasia that becomes much more pronounced. And in later stages of Alzheimer's disease, an individual may have a very reduced ability to then say anything that more than a few words. Sometimes people are singing rather than speaking, or humming because they can't put words together. Occasionally, aphasia is the early symptom of Alzheimer's disease. We think of it as less common than the memory variety. We think about Alzheimer's disease starting with forgetfulness, and that is true most of the time. However, occasionally, the aphasia or the language disturbance can be the prominent early feature.
And we have a follow-up question, I believe, if I'm reading the chat correctly, is that will these newer treatments be applicable to those individuals who are living with aphasia?
Yeah, this is a super question. So if the aphasia is due to Alzheimer's disease, then yes. So how would we know that? You would need to have an amyloid test. Would that be a spinal tap or a PET scan or one of these blood tests that will be coming? In some way, shape, or form, we need to know that removing amyloid is going to be helpful. And we think it will be helpful, whether it's the amnestic or memory variety of Alzheimer's disease or the aphasic variety, as long as amyloid is at the root of the problem.
All right, and just kind of sticking with the topic of aphasia, we have a question that says, would aphasia cause the loss of speech?
So aphasia is the entire thing, just like memory. So aphasia refers to a language impairment. It can be mild, it can be very severe, it can be anything in between. It can affect mainly expressing oneself or mainly comprehending what other people are saying, or both. So aphasia is the whole thing. Aphasia isn't a disease, it's a syndrome. So it doesn't tell you what's causing it. So Alzheimer's, as we said, can cause it. A stroke can cause it. A head injury could cause it. So I'm not quite sure if I've answered the question. You might need to ask me again.
All right, I might give them a chance for them to maybe pop another question. So
Okay.
now I'm going to move over to our individuals who had their hands raised. So Sam, I'm going to give you permission and you should be allowed to talk now. All right, so Sam, if you want, you're good to unmute yourself.
I'm sorry, I didn't realize that I had raised my hand. I will lower it. I
Oh,
apologize.
that's okay, no problem.
Nice to hear your voice, Sam.
All right, it looks like we have another individual who has their hand raised as well. So Trish, I'm going to give the option to talk, and if you have a question, go ahead. Whoop. Wrong person. There we go.
Sorry, if it's me, the Trish that asked the other questions, I do not have any more. I guess my hand didn't get lowered at the appropriate time.
That's okay. It's always nice to check. All right, thank you for letting us know. So we do have another question then. And this question reads, a person diagnosed with a cognitive impairment of 4+ years and is taking rigavastine, I hope I pronounced that properly. Can the individual take lecanemab or one of the new medications?
Yeah, you did great. So rivastigmine, that's a medicine like Aricept or donepezil, galantamine. It's one of the older medicines, but it's the best we've had. That group is the best we've had to treat symptoms. So it boosts acetylcholine. It absolutely can be taken in conjunction with the new medicines that are coming. So whether somebody's enrolling in a study with lecanemab or donanemab, these new antibodies, or trying, an immune-based therapy to reduce inflammation, yes, it can be taken. And in terms of aducanumab, which is the one that Health Canada is deliberating over, if it's approved next year, yes, rivastigmine could be continued.
All right, thank you. Oh, it looks like we have 2 more individuals. Oh, maybe.
Haha, we thought we'd have no question.
Maybe. All right.
It took the brave soul to start us off.
That's right.
Give me 1 second. All right, Trish, I see your hand raised, so let us know if you have a question or not.
I do not have a question and I do not know how to lower my hand.
I
I
will.
am so sorry.
No worries.
That's okay. Don't worry. I can help you out with that. We have one more question in the chat then. So we have, what does donepezil do to treat Alzheimer's disease?
Okay. So donepezil is sometimes still referred to as Aricept. Aricept was the first medicine to be approved in Canada to treat symptoms of Alzheimer's disease, and that goes back to 1997. And then a couple of others, rivastigmine and galantamine, followed. And the way they work is by preventing the breakdown of a chemical called acetylcholine. Acetylcholine is a chemical that brain cells use to speak to each other. And in Alzheimer's disease, brain cells are dying and they're not making enough acetylcholine. So the brain cells are not connecting with each other properly and they need to send messages. So with donepezil, we prevent the breakdown of acetylcholine. So there's more acetylcholine to help brain cells communicate. That's basically it, but it does not, donepezil cannot replace all of the acetylcholine. So we get a partial benefit.
All right, thank you.
Wow.
So I see, for now, I see nothing else in our chat, no raised hands and nothing in our Q&A. So I guess Dawn or Denise or any of our other panelists, if you have any questions you'd like to ask.
Don't have questions, but I'm ready to thank Dr. Cohen. Dawn, did you have any questions before we wrap up?
No, I think we've answered some questions. So if you want to do the thank you.
No. So Dr. Cohen, thank you so much for a very informative presentation today. We all need hope that one day we're going to defeat this disease. And so thank you so much for your hopeful message today and for sharing with us the encouraging advances that are happening in diagnosis and treatment of dementia. We truly do appreciate your time and expertise to share all of this valuable information with our audience. So thank you so much.
I
want to thank you. I want to thank everyone who has joined us here today to learn more about dementia and the most recent advances that are providing hope that you and your loved one can live a good life despite the diagnosis of dementia. And for those of you who joined us earlier this afternoon, I hope that you did learn more about the Alzheimer's Society and that you can reach out to us for support wherever you are on your dementia journey. I also want to thank our staff who worked behind the scenes to make this afternoon possible. We're all continuing to learn how we can reach people virtually as we wait for the pandemic to pass. So thank you to the staff. And while our programs are operating virtually at this time, we are also starting to welcome clients back into the office. Our contact information is going to be available following the conclusion of the presentation. And we urge you all to reach out to us, whether you're a person living with dementia, a care partner, a family member, a healthcare provider, or a member of the public just wanting to know more. We're here to provide you with that support and hope for tomorrow. So should you wish as well to support the Alzheimer's Society through a donation to support the important work that we do, the contact information will follow. And it's through those donations that we're able to reach more individuals living with dementia and care partners and provide that vital support that they do require. And finally, if you're interested in joining our amazing volunteer team, please get in touch with us to learn more. So again, thank you all for attending today's presentation, and we do look forward to speaking with you in the future.
Great to be with you. Thank you.